Good afternoon, everyone. I thank NANDED team and IMA Maharashtra medico-legal team for giving me this opportunity. Today's my topic is death on table. Death on table म्हणजे प्रत्येक एका सर्जनच्या लाईफमधलं नाईटमेअर आहे. So we will discuss today how to deal with this situation. So death of table is always a possibility in any surgery. By definition, death on operation table refers to demise of patient during surgical procedure. Now we discuss it with two of cases. First case is Arunaben Kothari versus Navdeep Clinic, in which a patient with road traffic accident with injury and deformity of right arm, for which operation was planned, but the patient died during surgery. In this case, allegations raised that the amount of drug used for anesthesia was more than maximum dose, and pre-anesthetic checkup was not done, and proper monitoring was not done intraoperatively. Here, State Commission stated that the anesthetist and surgeon should explain the reason for complication and death in operation. So here, onus lies on surgeon as well as on anesthetist. What happened that led to death? And in this case, anesthetist was held negligent for not acting on pre-operative records and not ensuring presence of defibrillator and failed to manage hypoxia during operative procedure. So compensation was awarded around 4 to 5 lakhs rupees, and both surgeon, anesthetist and physician held liable. Second case is Dr. L. Prakash versus State of Tamil Nadu, in which a fracture femur patient referred to orthopedician and he posted him for surgery. Anesthetist gave spinal anesthesia, but during surgery, surgeon came to know that there is no active bleeding from surgical site. When he informed anesthetist, they come to know that patient is not responding and gasping. So even after resuscitation, patient died. So on investigation of this case, patient died because of respiratory failure as a sequel of anesthetic drug administration. Here, anesthetist failed to check up pre-operative condition of patient and proper intraoperative monitoring of patient. So, civil as well as criminal liability was raised against anesthetist. So, 100% of surgery is success of surgery is impractical. So even with this cannot be taken for granted that patient will come out better or even alive. So now we will discuss the mortality rate in various surgical specialties. As per statistics of WHO, 1 in 1 lakh patient die during surgery on table. Percentage are 2% in cardiac surgery, 5% neuro, 1 to 2% in general surgery, orthopedic surgery and obs-gynec. And more common gross underestimated in gynec surgery, such as 1 in 12,000 in cesarean section, 1 in 4,000 in hysterectomies, 1 in 8,000 in laparoscopy, and 1 in 15,000 in minor procedure. And surgeon is caught at least once in his lifetime in this tragedy. Now we will discuss what are the causes of death on the table. They are anesthesia-related complication, surgical errors, and patient-related factor and equipment failure. In anesthesia-related complications, because of overdose of anesthesia, a patient may complicate and he will die. Second, inadequate monitoring, failure to properly monitor patient sign, and delayed recognition of the complications. Then inexperienced anesthesia provider, lack of experience leading to error in judgment, and communication breakdown between anesthetist and surgeon, which leads to multiple complications such as respiratory failure, airway obstruction, pneumothorax, aspiration, cardiac arrhythmia, etc. Then surgical errors include incorrect surgical site, operating on wrong site of the patient, or inadequate surgical technique, and injury to vital organs such as blood vessels, heart, etc. Patient-related factors include pre-existing medical condition such as heart disease, lung disease, then some medication interaction and anaphylaxis with anesthetic drugs and other drugs which we administer during anesthesia to patient, and some obesity and comorbidities which may increases the anesthesia related complication during surgery. Then most common is equipment related factor, and which is not in our hand, that is anesthesia machine malfunction, ventilator malfunction, then monitoring equipment such as infusion pump, ECG, etc. And as per now, there are 5 to 6 cases in last 6 months about electricity failure and leading to stoppage of machines and death of patient on operation table. Now, as per literature, the American Society of Anesthetists, that emphasizes the importance of proper anesthesia care, equipment maintenance, and emergency protocol. And WHO surgical safety checklist, which is a standardized tool to ensure critical safety steps to be taken before, during, and after surgery. So, before induction of anesthesia, a safety checklist is very important before taking patient to OT, such as patient site, then patient, all the pre-op investigations, whether fitness was done or not. This checklist is important before taking patient in OT. As well as after taking on OT, pre-monitoring checklist, intra-op monitoring of the patient by anesthetist should be maintained. Now, how to prevent it? So, prevention and preventive and strategies are very important. It includes improved communication and teamwork. So, we must encourage open communication between our staff members, our OT team, so that we have a collaborative decision making. Then, as I said, standardized safety protocol is very important. So, we must have a proper checklist, intra-op monitoring chart, guidelines which are mentioned in NABH. So, we must have a practice to adopt this checklist protocol in OT in every case. Then enhance patient safety measures such as proper identification, site marking, and pre-operative preparation. Then regular equipment maintenance, their CMC, AMC is to be done routinely, and that they should be done and calibrated regularly, so they should function effectively during operative procedure. We must upgrade ourselves by continuous education training programs such as like this CME, so that we must upgrade ourselves in surgical technique and emergency preparations. Most important is incident reporting. Encourage a culture of transparency, reporting, and analysis of adverse events to identify areas of improvement, and involve patient and their relatives in care decision and safety protocols. Many times patients also suggest us how to improve in our surgical practice. Now, what pre-operative measures to be taken? It includes a very clear communication. Establish open and honest communication with patient and their relative before surgery. You must inform them in simple language what procedure you are doing, what is outcome of that procedure, what anesthesia you are giving. Second, informed medico-legal is informed consent. And consent is anesthesia consent and surgery consent should be separate. Anesthetist consent should be taken by anesthetist. Surgical consent taken by surgeon. Anesthetist should do pre-anesthetic checkup. If he wants, he can do extra investigation. He may delay procedure if he thinks patient is not fit. And surgeon also explain all risk and complication associated with surgery. In preoperative counseling, provide emotional support and counseling word to patient and his relative, because they are also in stress. So give them support that you will do well, you will come out of this procedure. And very important is realistic expectation. Manage expectation by providing realistic information. Never say 100%. Never say you are going to be get cured 100% by this surgery. Always give them that I will try 99%, but always 1% is there which is desired by your fate of the patient. Then encourage support system to have with patient. So ask patient to have his family and friends around him OT. So patient is fully supported by family during this stressful period. So even if we take all this precaution, there are chances that real life incident of death on table happen, even if the hospital is big, cooperate, having all protocols. So there are examples that death on table can happen at any place. It can also, I am enlisting some of the examples, such as surgical error at AIMS Delhi during transplant surgery, anesthesia equipment failure at Mumbai JJ Hospital, then surgical negligence as Bangalore's Phenomena Hospital, and anesthesia-related death during Chennai's Apollo Hospital, and like this at Calcutta and Hyderabad Nizam Institute. So though these institutes are reputed, the chances of death on table is can happen at any place. So we must be prepared to how to handle this situation. So before declaring to relatives and informing police, very important, during intraoperative procedure, when you feel that patient is sinking, keep relative informed that patient is serious and collapsing. Tell them that some complications has happened and you are trying best to revive him. Involve that patient's relative in saving process. So patient's relative came to know that you are doing something to save patient. Then in between you maintain all relevant documents such as case paper, anesthesia notes, surgeon notes, resuscitation note and visiting doctor notes, because they are required immediately after that death on table case by authorities. And these notes should tally with each other. Similarly, preserve all broken ampoules of injection and no expired drug should ever be found in OT. Leave the thing as it is, because after death on table, it is like a crime scene. So if you clear up OT, it is like you are not supporting investigation and you are hiding something. So do not clear up OT immediately. And take back all prescription from relatives, specifically emergency drugs. Because patient may tell later on that these emergency drugs are advised by OT sister on 11th hour, means they are not available with you. So what will be our immediate response in first 24 hours? First and foremost is help yourself from physical violence, because death is unacceptable. So relative may behave like they can beat you or they may vandalize hospital. So most important is inform superintendent of hospital if you are working in a corporation or multidisciplinary hospital. Inform police, security guards and keep emergency exit available. After informing police will do first Panchanama, hand over your all the documents by proper numbering them, and see that you must write down the police buckle number and his name on your records. Always preserve the scene, means preserve the operating room and equipment at its original state, and secure all medical records. From your side, you do medical investigation. So what lead to death, means take information from surgical team, anesthetist and staff. What gone wrong leading to death. So can you answer it well with authorities and patient's relative. And keep all hospital license ready for inspection. This includes your hospital registration, fire, MPCB, biomedical waste and AMC, CMC of all equipments. And the most stressful issue in this case is how to break a bad news, means how to tell that patient is died on operation table. And why we worry? Because damage to reputation, facing multiple questions from relatives, fear of mob violence, handling police inquiry, handling medico-legal issues such as arrest, court cases and judgment, compensation amount and loss of confidence. So we must handle this situation by proper support system, and support system is very vital. Surgeon, anesthetist, our friends, OT staff, administration of hospital, senior colleagues are the main support system. So ask them for help, tell them to gather near OT, tell them to relax, never worry but be concerned, and review the sequence of events. And always do not adopt a blame culture. Do not blame your anesthetist or your OT staff. Whatever happened is happened. Now you have to deal with the situation. Keep proper documentation ready. There should not be any discrepancy in record and there should not be any loose comment by junior staff. The most important is how to react with the reaction from the relative, because the relative may react in shock, anger, guilt and depression. So it is very important to manage relative's reaction. So you must be sensitive to relative. When you proceed, read the verbal and non-verbal clues from patient's relative face and body language, silence, tear. If they stopped listening to you, you also stop, give them time, and again ask them opportunity to ask question. Make arrangement for taking away the body and register death. So a communication skill is very important, and a communication done by a senior consultant will prevent litigation in many ways. So it potential offers most rewarding aspect of total patient's care. And what relatives want? Relative wants a empathy and compassion towards them and clear explanation what event leads to death. While explaining to relatives, always avoid medical jargons such as anaphylactic shock, hypovolemic shock, because patient relatives don't know these terms. So explain them in a simple language. Offer them support and counseling services. Tell them that you will come out of this and you will help him to come out of this loss, and you are with them. So they may feel some empathy, that you are showing some empathy towards them. And always give respect and dignity to relatives. Do not blame them. Do not blame that you brought patient late or you stopped that medicines, that's why patient died. Because patient relatives are already in loss and grief. So always respect them. And do not show aggression and put blame on the relatives. And do not refuse post-mortem. Always suggest it from your side. So death on table raises a number of special medico-legal questions. As patient's relative has no access whatsoever to OT during procedure, the onus lies on doctor in OT to explain what events that happened there. So doctor must explain those events and the relatives get satisfied with that explanation. Now we will see the medico-legal aspects. Death on table can lead to medico-legal cases in India, which is governed by Indian laws, IPC, now BNS. The legal implications include, in case of death on operation table, the hospital and medical staff can face implications including criminal liability, such as doctors and hospital staff can be charged with negligence or culpable homicide not amounting to murder as per IPC, now BNS. Then second is civil liability. The hospital and medical staff can be sued for damages by the patient's relative. And this is done by medical consideration, whether informed consent was taken or not, what standard of care doctor and anesthetist provided, whether there is any negligence or gross misconduct, or whether there is any equipment failure. Now, what is legal representation after death on table? Maybe we have to seek legal help. Consult a lawyer who specialized in medical negligence and medical legal cases. Understand your rights and obligations. The lawyer will guide you. What are your rights and how to cooperate with the investigation. Then it may proceed with police investigation, civil hospital or magisterial inquiry, or court proceeding. Now this death on table investigation is done by a team including forensic expert, anesthetist, surgeon and specialized of that concerned specialty with preset of questions. These questions are whether informed consent is taken or not, whether that procedure is necessary or not, whether it is essential to save life, whether patient properly examined or not, whether patient is fit to undergo both procedure. All these questions are asked to decide whether there is any negligence from doctor's side. So we must cooperate with the all investigation and provide necessary information to facilitate the inquiry. Now, how to prepare for the future to avoid this? So we must review and improve our practices by improving ourselves, improving documentation, improving communication, as well as we must seek support of organizations such as Indian Medical Association, Medico-Legal Cell, Association of Medical Consultant and Medico-Legal Society of India. There are various organizations which will provide support in such cases. And always very important is maintaining indemnity insurance. So surgeons, anesthetists, physicians should have proper indemnity insurance means if you have any financial crisis, so we can compensate by indemnity insurances. So documentation and reporting is very important because documentation only saves you in court of law, and in death on table case, no death certificate should be given. Always ask for post-mortem from your side. There are many cases, but at time is less. I will enlist only few of them. That death on table because of some anesthesia complication in Maharashtra's Panvel Hospital, because anesthetist found negligent because of improper PSC and intraoperative monitoring. Second case is Srimati Reshma Sutar versus Shri Amol, in which it is also related with anesthesia. And second case is death on table because of poor surgical skill, in which Dr. Lakshman Joshi versus Trambak Godbole, in which excessive force is used and patient died on table. Then some cases due to equipment failure, which includes malfunctioning ventilator in Municipal Corporation of Delhi and power failure in state of Maharashtra versus Sai Charan Medical Foundation case. So in conclusion, 100% successful surgery is impractical. So we should be ready to handle all type of outcome, including death on table. Anesthesia, surgery, equipment and patient morbidity related are the factors of death on table. Prevention is the key, and empathy and compassion to the relative is very important to prevent from litigation. Support system like from senior police, bouncers, staff should be taken at such crisis. We should be very careful while breaking bad news. Get knowledge of medico-legal aspects of death on table. Always ask post-mortem from your side and upgrade your knowledge and get a good indemnity cover. So at the end, last but not the least, every new case brings challenges and obstacles. Stop thinking about it constantly at home. Keep your moral and self-confidence intact and learn the lesson it teaches, and take a small break. Thank you.